Okay, thank you, Holly. Thank you for coming, everybody. I'm going to switch over to the PowerPoint. Just give me a second here. So that's going to be what we're going to be looking at for the next 45 minutes. Takes me a second. All right. There you go. Did everybody see the PowerPoint?
Yes.
Okay. Well, as you know, we're talking this morning about mental illness in persons with intellectual disabilities. I want to say that an hour is probably not enough time to cover this topic. So we're really basically just going to be, generally touching on some important points. But it's just a large topic, and it's not something that you find a lot of information about. Certainly, when you think about the way practitioners such as myself are trained, they don't get a lot of training in how to provide services to persons with intellectual disabilities. So I think today's lecture is going to be very helpful to you if that's something that you're interested in. Just a quick overview. We're going to talk about prevalence of mental health disorders in intellectual disabilities. We're going to look at the general considerations for how treatment needs to be adjusted and provided because people with ID have unique needs. And we're going to talk specifically about the needs of children with intellectual disabilities, some of the problems that they experience, and then, of course, adults as well. And then treatment considerations. And I want to leave some time to talk about crisis, times when a person with intellectual disability needs emergency care. Just a few comments about that I think are very important. First, we should talk about the prevalence of mental health disorders in people with intellectual disabilities. Now, we're talking about a group that in America is about there's a lot of people with ID out there. Hell,
Dr. Schmoyer, people are still having some trouble hearing you. So, yeah.
I'm getting a message that says my connection's unstable, but I'm not sure why that is.
Yeah, it could be the weather. That's part of technology. We always have those issues, but yeah. So if you could speak a little louder might help. I'm not sure.
Is that better? Can you hear me?
It's a little bit better, yes.
Okay. What I was going to say is that for people with intellectual disabilities, they're just as likely to get major severe mental health disorders that any of us can get. So the percentage of people who have, say, schizophrenia or any of those types of disorders, they're just as likely to get them as anybody else. But compared to the regular population, people with ID actually have a higher risk of lots of other psychiatric problems. It can be anywhere from 15% to 40% of the population of persons with ID can have a severe mental health disorder. And we see that in our practice quite a lot. If you can see the slide there, this is from the DSM-5, and it talks about the rates of disorders. So, most commonly, almost 20% are behavioral disorders. And that's a lot of what we see is behavioral disorders. Mood disorders are next. And then, of course, a certain percentage have autism as well as ID. And psychotic disorders are also prevalent, as are anxiety disorders. So this is a very, large amount of psychiatric illness in the population of people with intellectual disabilities. People with ID already have challenges just because of having ID. Intellectual disability affects pretty much every aspect of their life. So, we've got you can see it there at the top of the slide, pretty much every part of their life is affected. Their social life, their ability to, practically solve problems and care for themselves, and just basic skills. Skill deficits are a really large part of the problem for people with intellectual disabilities. In addition to mental disorders, we also have neurodevelopmental disorders. People with ID, they're developing. They're developing usually slower and later than the rest of us. Sometimes they have specific medical problems that are physical, in addition to having mental illness, having always to be a problem, and sometimes stereotypical movement disorders, tremors, sensory problems. You can see there quite a list. Sleep problems are prevalent as well, and when sleep happens to be disordered, just about every one of these things is made worse. So addressing sleep is one issue that we see very often. We have to manage in people with ID. And of course, there's self-injurious behavior, which we can talk about if we have time, and just lots of issues that are separate from the mental illness itself. So let's talk about general considerations of mental health with ID. I want to emphasize that we're talking about providing mental health counseling, or what we call psychotherapy, to people with ID, and that is not something that is very common. There's not a lot of training for it. Many people in mental health circles don't consider it something that's useful for persons with ID, but I can tell you that it's very useful, but it has to be modified. It has to be tailored to the needs of the client. So you're not going to see a lot of journal articles about it, but it really is something that can be done and can be done effectively. My first point here: level of a person's IQ does not equate to their ability to participate in therapy. What I mean by that is, even though a person may have a lower IQ, that does not mean that they can't benefit from talk therapy. They certainly can. But we have to take each person as an individual. We have to approach them based on their specific personal abilities and their personal needs. And if we can do that in an effective way, therapy can actually be done very well. One of the considerations is how well can the client verbally report? How well can they tell you about their symptoms? How well can they describe to you what they're feeling and thinking? And sometimes, they need a little coaching in order to do that. They don't usually have the vocabulary that you would like them to have for doing talk therapy, but they can certainly develop it. And there's a role for the therapist to adapt themselves. As a therapist, you get to know the person, and you get to understand their idioms and their ways of expressing themselves. And you watch for behavioral indicators. People with intellectual disabilities generally will generate behavior as a way of communicating. And a lot of the things that they tell us are really nonverbal. They're part of their nonverbal communication. You have to watch that. I'll give you an example. One of my clients, who I've seen for many years, he does not verbalize anxiety at all, but he definitely experiences severe anxiety. And the way you can tell is he will take his fist and he'll pound on his knee with it. And he'll tense up, and you can see him hitting his leg. And it starts out as a very subtle thing. You might even not notice it at first if you're not looking for it. So in the therapy for that gentleman, one of the things we do is we coach the people that support him to watch out for that sign, so that they can then talk to him and interact with him about what he's anxious about. And it's very useful during the therapy session as well, because you can see his response. And although he's very gifted verbally in other ways, he's not very good at using emotion words. So we watch for the behavioral side. Fund of knowledge impacts therapy for people with ID. That's one of the major considerations. People with an intellectual disability are not as well educated as we would like them to be to participate in therapy. So what they understand is a factor. And so sometimes you need to take an assessment of that, figure out, okay, is the person I'm trying to help knowledgeable about something important that I need them to know? So there's a lot of educational approach that goes on in therapy for people with ID. We're trying to help them understand things that normally would be outside the scope of their knowledge. Just being able to understand the value of reporting feelings is sometimes new to the person. Often the person who has ID did not request therapy themselves. They didn't come to the office and say, "Oh, I'd like you to help me with this," or help me with that problem. They're usually brought there by somebody else. Someone else sees a need and brings them there for therapy. So they may not have any idea why they're there, what they're supposed to be accomplishing while they're there. And so on the front end of therapy, you need to really acquaint them with what's going on, why is this happening, and help them understand that they do have some control over what goes on in therapy. They're the patient, even though somebody else brought them there. They have a lot of control over what they tell others. They have to know about confidentiality. They have to be educated about things that are usually outside their fund of knowledge. Fortunately, we have what are called skewed abilities. People with intellectual disabilities sometimes have higher order skills in some areas, even though they have lower skills in others. So when helping someone through the process of the therapy, it's good to kind of understand what are their abilities, what are the things they're good at, and to kind of, trade on those, like focus on those things that they're able to more easily do. Are they more visual? Are they more of an auditory learner? What kinds of things can you do with them that are good for them, that fit their ability profile? Role play works very well with some people with intellectual disabilities. With others, it doesn't work at all. It confuses them. So you kind of have to tailor the approach to the person. Use a therapy technique that will not be confusing to them, something that they have an ability to grasp and understand. A good example of this would be video games. People with intellectual disabilities love video gaming just as much as everybody else seems to. And if you want to help them, you got to be knowledgeable about the things that they're knowledgeable about. So sometimes just understanding what they're doing in their recreational time can help too. I think it's important for everyone to consider genetic disorders. Many people with intellectual disabilities have that disability because of because of a genetic disorder. Everything from Fragile X to Prader-Willi, Down syndrome, Cornelia-de-Lange, to name a few. And a lot of these disorders are, you can get genetic testing for them to verify what the disorder is. Now, I'm not saying every person who has ID should get genetically tested, but if you suspect that they have a genetic disorder of some kind, getting that tested can be a very helpful thing, because once you know what the disorder is, it does sort of predict the kinds of problems that they will have. It'll predict impulse control issues. It'll predict dietary issues. It'll give you a much deeper understanding of what the person is struggling with. So sometimes that can be a very big help. Hershey Med used to test doctors, they still do. I know that in the past that they had, and it's been helpful to me at times when I've had a client who was diagnosed, so I can then understand the disorder more thoroughly. Then of course we have a developmental level issue, kind of a separate issue from the intellectual ability level. It's the developmental level. They're not a neat match. When you get IQ testing done, you can estimate what we call a mental age from an IQ score, but really in truth, they don't match up ideally. So what the IQ says a person's developmental level is not really, it's not really accurate. It's really much of a separate issue. So emotionally speaking, what level are they at developmentally? Are they like a preschool age person? Are they like a middle school age person? Are they like a teenager? Where are they at? Separate from their age. Their age is what their age is, but you might have a 40-year-old person with ID, and they may developmentally be like someone who's in middle school. You have to kind of approach them that way so that they'll understand what you're trying to do. You cannot approach them like someone who is their chronological age. Some specific things about children and teens with ID. There are developmental delay effects. We expect children of a certain age to have some self-control and ability to pay attention and focus. Very much not true for children and teens with ID. They're behind. They're behind in developing those skills. So we can't expect them to be the same as a child the same age without ID. There are sensory concerns. Certainly you see this a lot with children with autism, but it's not just children with autism. It's children with ID in general may be struggling with sensory problems such as hyperacusis. They may have a very strong sense of hearing, and certain sounds might actually distress them more than we would be distressed, or more than a normal child would be distressed. And part of that problem is the difficulty of what we call habituation. Normal children, they get used to stimuli. They get used to what they're hearing, and they adjust quickly, what we call habituate. Children with ID who have sensory concerns don't habituate as quickly. So we have to be careful of what we do with the sensory environment. Part of the developmental delay results in basically a functional attention deficit disorder. Children with ID, they're like children with ADHD. They struggle to pay attention. They struggle to focus. And my screen has, I've lost the video feed. I'm wondering if you guys are hearing me.
We are hearing you.
Okay, it just, for some reason, my video screen vanished. So ability to focus is a problem for children and teens with ID in therapy. So you have to adjust what you expect them to be able to do. So you may only have a few minutes of that hour from session to session. Children in general, but especially children with ID and teens with ID, have disorders that fit into broad categories of internalizing or externalizing. So we have internalizing, which is withdrawing, being anxious and being uncommunicative, being socially isolated. Then we have externalizing disorders, which I think we've all seen with people, acting out behaviors, tantrums, even physical aggression. So all this kind of gets summarized under categories in diagnosis: attention deficit hyperactivity, disruptive behavior disorder, mood disorders, and of course we see a lot of anger as well. And being that they're developmentally delayed, they are struggling to develop autonomy, and it takes them lots of time to do that, way longer than a typical teen would take to develop some sense of independence. So you're not just dealing with the mental health disorder, you're also dealing with the development of the person. Adults have their own problems. One of the biggest problems for adults with ID is non-normative phase of life transition. People of the same age who are not the same, they're developing lots of friendships, they're dating. Sometimes they're getting engaged and married, or they're doing other things like joining military service. Person with ID is usually way behind them. So they're seeing people of their own age pass them by. Some of their classmates are doing things that they want to do, and they're just not developmentally ready to do it. We see impulse control disorders, acting out behaviors, and a lot of this is due to the delay in the frontal lobe of the brain being developed. So in a sense, they functionally have what we call frontal lobe syndrome problem. The frontal lobe of the brain helps us to organize our behavior. It helps us to plan what we're going to do and anticipate consequences. People with ID, they're developing that. It's not fully developed even at young adult ages, and so they have problems with impulse control. One of the biggest issues in therapy for people with ID is the diagnosis of their problem. It's difficult sometimes to get an accurate diagnosis. We've seen it in past times, and even not very long ago. People who have been diagnosed, who have ID, might be given a personality disorder diagnosis. Sometimes that's not really accurate because of the function of the brain, the organic problems in their brain function, like I've been talking about with the frontal lobe. They may appear to have a personality disorder, but it may not be necessary to diagnose them with a personality disorder. It may be an inaccurate diagnosis. So we have to consider, is this really a diagnosis that they have and that they need treatment for, or is this really just a feature of how they've developed to this point? Psychosis, yes, it does happen in people with ID, and they can develop delusional thinking. However, we have to consider, is it a delusion or is it possibly fantasy? Being developmentally normative, younger people tend to have some fantasies about celebrities, about important people in their life. They can have infatuations. They can, their thoughts can run away with them. So we have to be careful not to be hasty in labeling something as a symptom of psychosis or delusion. It could just be normative fantasy-like thinking for that person. And we've seen this a lot, especially in clients that have Down syndrome. They can develop some really powerful fantasy thoughts, fantasy life, that would take up a significant amount of their time, but it would be a mistake to treat it like a delusion or to treat it like a psychosis. It's not something you can medicate, and so one has to be very sure what their diagnosis is. Same thing with mood disorders. Mood disorders are very prevalent in people with ID, and they have anger many times as well. But we have to consider, based on their developmental progress, the age that they are emotionally, is it possible that their mood is normative for them, not necessarily a disorder? So some considerations. Identifying a mental health disorder is helpful. We have to be careful with how we decide what disorder a person has with ID. So it is difficult sometimes to, decide, but once you decide, it's helpful to have that diagnosis. Things like how
Kind of losing your sound there a little bit, Dr. Schmoyer.
How's that now?
That's a little better, yeah.
If we want a client with ID to consider a different behavior, changing their behavior, how well do they understand that? Can they conceive abstractly of what that would look like, and what it would be like for them to try to act in a different way? So we may have to use images, we may have to use actual demonstrations. We may have to help them, come to grips with what we're trying to get them to understand. So their ability to think abstractly does impact on their ability to participate, and we may have to adapt therapy to do that. Same thing with the ability to communicate verbally. Sometimes I use emotion word lists to help them learn new vocabulary. We try to help them to communicate better so that they can participate better. So once again, we have to modify the therapy to fit the client's needs. Many things can be done to do that. Feedback systems. I use a lot of charting I chart clients' behavior so they can see that it's improving. They can also see when it's not improving. And that can sometimes be helpful for them so they can kind of grasp what's going on. And other ways of assisting them, which I'll show you in a minute. So the question often comes up, are they appropriate for outpatient talk therapy or not? And in some cases, we find that they really need both that, but also behavioral intervention. And that can be done then in their own home environment or their school environment or their work environment. So it's not always sufficient just to do talk therapy. Sometimes you need to do behavioral intervention as well. Medication can be very helpful, but again, you have to be very sure of your diagnosis before you consider referring the client for medication. Let's look at some treatments. We're going to talk about a feeling reporting system that I've been using, and we also want to look at pain and some self-calming training and anger management tools. This is just one portion of a feeling chart that I use. I actually have a chart that's much larger than this, but this is the basic chart. And I will often have the client, tell me how they're feeling at the start of each session. And this is an example chart that I use. I'll read it out loud to them. If they're able to read it themselves, that's fine. But typically, I'll read the choices and point to the faces and ask them to tell me which one is how they feel today. This is a system that's based on that kind of a chart. Basically, I ask them to pick two feelings, and it's okay to pick the same one. And often what will happen is the client will pick happy, describe how you feel today, and sometimes they will pick angry or scared, confused, tired. So now we can talk about both, why they're happy, why they're angry or scared or tired. So it helps them to be able to explain more clearly what's going on. If you just ask them how they feel, the average person with ID will say they're fine. How are you today? Oh, I'm fine. Everything's good. Well, obviously it's not all good if they're there for therapy. Something is going on. So we try to help them express a little more than just being fine. Pain is a problem for people with ID, just like it is for the rest of us. Face pain rating scale. This is in a lot of medical facilities, and it makes it a lot easier for the person to share how much pain they're in. If you ask them how much something hurts, you probably won't get an accurate answer. So if pain is a consideration of the treatment you're doing, you may want to use this because this will allow them a way to give you a much more accurate understanding of how much they've hurt. When I'm doing anger management therapy, this is the way I explain the level of anger to people with ID. I use my hand, and they have a hand, of course, and this also works for people with visual impairments because you can actually sit there and you can, you can touch the fingers of their hand as you're explaining to them the level of anger. But it works even if you can't see it. You can see the picture there. One is the lowest level, and so as your fingers get larger and you get toward the thumb, you get more angry. So typically this is how I explain rising anger. I want the person to learn to monitor what anger level they're at, and then we try to apply strategies at level 2 and 3 to help them prevent getting to 4 and getting to 5. That's a very simplified explanation of how we do it, but I just wanted to share that with you. This is an example of how to adapt therapy so that a person with ID might understand the concept of rising anger, of becoming agitated, so that they can then, do something about it. The anger level then allows you to talk about it. So once you are able to understand what number you're at, then you can use the words that go with that number to express yourself. And this is a script here that we use sometimes to help the person learn to tell others what's going on. So they're not just using the scale to know where they're at, they're now telling somebody else. Or you're making variance. And as you see in step 3, I'm not going to keep talking to you. I'm going to take a break and walk away. And that's actually a strategy known as self-instruction, telling yourself out loud what you're going to do. But it's embedded here in the communication strategy. I've been using this with a few clients, telling them to visually look at the different ways they can express themselves. And sometimes the visual gets them to understand where they're at. They can relate to the red as, you know, a very agitated way of presenting, and the yellow is lesser. And, you know, our goal, of course, is to get them to share, you know, things in sessions in a way that's not so intense, not so red. And so, you know, of course, the target is the smiley face. But sometimes this visual image allows them to understand what the goal is. For some clients that we do anger management with, the anger scale does not work. However, they're much better at reflecting on their own actions. So we use this, help them learn to track what they've been doing. And of course, we want people to have 1s and 2s, not 3s and 4s. And once they've got the grasp of this concept, they can try to stay at a 1 or a 2, which basically shows some self-control. They might get upset, they might do something that they shouldn't, but as long as they catch themselves and then, you know, return to a baseline behavior, they're a 1 or a 2. We want to avoid 3s and 4s, of course, but sometimes that's just the truth. That's what happens. Some crisis considerations. FOF, that's flight or fight, and often when we're thinking we should possibly take a person with ID to the emergency room, it's because they're in an agitated state, or they're in a state of flight or fight, which is largely a biological case. What we see then is what we call baseline symptom exaggeration. Whatever is true for them on an average day is now even more so. The symptoms become exaggerated. That does not necessarily mean that they need an emergency, but it could. So let's say you decide that it's really out of control or it's escalating and you need to go to the emergency room. You have to consider what you can and can't do in a crisis. And here's the hard truth. You cannot appeal to the person with ID in a crisis by saying to them, use your skills, use your coping skills. If they're truly in a severe crisis, they're probably not able to use their coping skills. If that's the case, yes, they may need to go to the emergency room. So you have to time things. If you're going to try to get them to do something hard, something that they're still learning to do, you can't do that in the height of the crisis. So what can you do? Well, you can try to decrease the stimulus load. Limit the number of people talking to them. Limit the amount of noise or distraction in the environment. Make the requests or the demands on them as simple as possible. Try to alter the environment so that it's less overstimulating. And anything that's not necessary, delay it. Don't make them do things that could wait till later. If you do choose to go to the emergency room with a person with ID, you're going to have to support them through the entire process. You cannot just leave them at the emergency room and expect the emergency department to take care of them. That's not going to work. Crisis units and ERs are typically not equipped to do a good job with persons with intellectual disabilities, but if you have support, someone there who knows the person, who can help communicate with the emergency department, that's good. Of course, these last couple slides are just to show you some resources. There's Dauphin County's crisis intervention contact information. and we have Cumberland County crisis as well, which has a mobile unit that can be helpful. If you are working with a personal ID and preventing they really ought to have supports coordination because real support intervention. Those are paid for under Medicaid and the waiver dollars and bring actual behavior intervention into the place where the person needs it. Habilitation services are also able to be provided. And if you click the link there, that'll take you to the Disability Services Index for the Office of Developmental Programs. And before I take questions, let me just show you there's my contact information. And if you have any questions after today's presentation, you can call me or email me, and I'll be want to know. So I think at this point we've got about 15 minutes left. I'd like to open it up for questions.
Does anyone have any questions they want to get to immediately? I know I had several, it brought me back to my niece Susan had Down syndrome. She's no longer with us. And she had an obsession, fantasy about being married to Michael Jackson. I mean, it took up a lot of her life. It drove my brother crazy, but you kind of explained that, and all her siblings had moved on and were out of the house. So, and my own son has done that. When his siblings got married, it was very difficult for him because he wants that too. And he's the oldest, but my question, if no one else has something, but please type it in the chat or speak up. You had mentioned hospitals are not equipped for people with ID, and I agree. We've had a lot of those issues this past year, but the COVID protocols, even though we are allowed, staff is allowed to go in, they were preventing that. They were not allowing staff through the ER process. So I don't know if you have any ideas of how we reach hospitals and nursing homes. That's been an issue with nursing homes, rehab, of how we get in there and do some education.
I've found that it usually is helpful to interact with the social services staff because they're more aligned to the kind of things that we do. And sometimes they can, help be a bridge to the ER staff. If we can at least get in touch with social worker who's on duty at that time, that sometimes is helpful. You develop a relationship with those persons over time. It makes it much easier to have someone with ID present into the ER.
Anyone else have any questions?
Holly, this is Susan. I don't have a question, I have a comment. I was told by a physician once that when you're in the emergency room and you feel like you're not getting what you need, you can ask, they have what's called patient advocates. So I think maybe that could also help for those that are thinking, they can't. I was thinking for my own children, and my granddaughter, one time there was an issue. She told me, ask for a patient advocate. I had no idea that even existed. They're there to support you in what you need.
We've found going to customer relations, the social workers actually haven't been very helpful. I think they've been under a lot of stress this year.
Yes.
And so whatever they call I think it's regulatory director in some hospitals, but UPMC actually has a disability resource center based out of Pittsburgh. We call them and everything changes immediately. They've been wonderful at educating, but it's only within UPMC. So yeah, we've had some major issues this year, but UPMC, their disability resource center has been fabulous.
Yeah, a number of years ago, I was called to an emergency room to evaluate a client with ID in the emergency room. And I'm not going to say where this was, but basically, when I got there, nobody was doing anything with the client. They were alone by themselves in a room and highly upset. And there wasn't anybody who they knew there. There was no one to advocate on their behalf there. It was pretty alarming. So, you know,
And that's,
important to have someone there.
yeah, and that's what, I mean, we all know that, yeah. I mean, even when you're in yourself, you have to self-advocate. So our people need staff or family in there with them. I had another question. When you were talking about developmental level, often I hear families say to me, oh, my son's like a 5-year-old, which always bothers me, but in a sense, they're saying they're on that developmental level. Although sometimes family assume that's across the board, and I always discuss like sexuality, that's not typically true. You know, they're when they're next to a beautiful woman, they're a 25-year-old if they're 25. So.
Well, yeah, and everybody with ID, they have skills in some ways that are age normative. They have some, and then they have many areas where their skills are deficit. So it's not really accurate to say that they're like a 5-year-old for every situation. They might be very capable, you know, in certain settings. They have the skills that are good for that behavior, but not in every setting. So it's really more of a range. If you do adaptive skill tests, as we do, you find out that they've got highs and lows. You know, they've got some age normal, you know, skills. They've got some skills that are like 5-year-old, 12-year-old, you know, 15-year-old. But it's very informative to have that profile and then, you know, try to adjust your approach to what they can and can't do.
I see Kathy has a question.
Hi, sorry, I had to unmute. Okay, so I'm just entering this world with my son who is 18, you know, and I have been basically his voice for 18 years. And I just did a work program with him, and they're like, no, this is like real work. We don't want your input. And I'm like, so I get a call later, he can't do the work. Well, yeah, instead of reinventing the wheel, how about I give you cues on what so I guess my question is, what do we do to make the world like, okay, yeah, they're an adult, but they need this, like I'm an assistive technology. I would be allowed into the ER. I would be allowed to help the work coach, you know, but they're like, no, we'll, you know, he's an adult now. We have to do it this way. And I'm like, so how do we change the world, I guess, is my question.
So you said there's a work coach. Is that job coaching? Are you talking about job coach?
Yeah, well, what they did is they got him a one-on-one assistant who I was allowed to talk to.